What is cancer? The picture on the left is actually from a very well-recognized and highly cited research article defining what are known as the hallmarks of cancer. And there are 10 things listed on that picture, and I just wanted to go through some of those because it's critical to understand what contributes to the development of a cancer. The first aspect of cancer is that the cells become self-sufficient or autonomous. And I've used pictures of self-driving cars off to the right because those do not require input from people. What you see in the bottom is what happens when autonomous driving cars aren't responding appropriately. And what cancer cells do is they don't require everything that a normal cell does. The second thing, showing the world's tallest and world's shortest men, is that cancer is cells that don't respond to the inhibitors in our body that keep us at somewhere between 5 feet and sort of 6.5 feet, or when you get gigantic like Roy. In the vertical, I do the horizontal gigantic. We are looking at cells that don't respond to the growth inhibition and hyper respond to things that promote their growth. They resist death. Here's a picture of Cheryl, Hope, any one of the ladies in the room, Wonder Woman. And they resist death. They can put up their little shields to prevent whatever's trying to kill them. And that's one of the reasons cancer becomes so challenging, is it looks normal to the body, so the body just says, okay, you belong here, when it in fact shouldn't stay. Cancer cells are immortal. They live forever. Normal cells will only divide so many times. This is a picture of the world's oldest tree. It's called the Methuselah tree. And it's more than 2,500 years old so far. We haven't been keeping cancer cells in labs that long, so we don't know if they'll live that long, but we think so. Cancers recruit the body's system for delivering them nutrients. Angiogenesis is a term where they actually recruit blood vessels to supply them with nutrients. Cancers will not grow beyond a certain size unless they recruit new blood vessels. A hallmark that is what my lab studies is the process of metastasis, invasion and metastasis. This is where cancer cells spread from the primary tumor, the originating tumor, and they go somewhere else. And we'll come back to that in just a little bit. The invisibility cloak from Harry Potter depicts how cancer cells they evade the immune system. They basically hide, and the new immune therapies that are being delivered now are trying to circumvent that invisibility cloak. Here's Broderick a couple of years ago, but he has altered metabolism, and that leads to a different way in which the cancer cells grow, and that's been recognized since the 1920s, but only in the last 7 or 8 years have folks begun to re-look at that. By the way, Broderick, you look marvelous. Cancer cells are genetically unstable. They generate a lot of mutants. One of the facts that you can write this one down. 1 out of every billion cell divisions in normal cells generate a mutation. 1 out of every 100 cancer cell divisions generates a mutation. So they're hyper mutable. And I couldn't find something with cancer, so I chose Lyme disease instead. But one thing that cancers do is they promote inflammation. You know, they make the immune system respond, but they twist the immune system into helping the cancer cells behave. So how do you get the cancer? Well, you can get it in any order of those hallmarks. And the ways in which you can get them are really directed by 4 things. First, it's a genetic disease. We know that the genetics of the cancer cell are screwed up. Lifestyle can contribute, as well as the environment. But most of how we get cancer really still is defined by bad luck. Just it's unfortunate. But in terms of prevention, altering lifestyle and environment are the two ways in which we're targeting it. So what are the causes of cancer? If you, most of us no longer drive standard shift cars where we actually have to change them, but I found a picture of the floorboard in a car, okay? So the things that cause cancer, the things that promote it or push cancer cells to become cancer, those are known as oncogenes. And those are like the accelerator. You push them and it makes the car or the cell go or divide. Tumor suppressors are normal things in every cell that we have. They're genes that make proteins that stop cells from dividing inappropriately. And those tumor suppressors are commonly involved and they get shut down or turned off. So cancer is both accelerator being pushed to the floor as well as removing the braking system in a cancer. You can develop a cancer because the cells are pushed forward, or you can have nothing change with the accelerator and just the braking system is removed. So you can get cancer both of those ways. And the third is only becoming recognized in the last decade and a half, and that's the clutch. You can put your car in a different gear, and the severity of disease or your susceptibility is based upon the ways in which that clutch is operated and which part of the transmission that you engage in the car. So, pop quiz. You didn't know you were going to get tested today, but everybody will pass this one. The question is, what percentage of cancers do you think are due to inherited mutations? Okay, less than 1%, 5 to 10%, half, almost all. A lot of you sat on the fence on that one and didn't raise your hands. My philosophy of life is the only thing you get when you're straddling the fence are splinters, okay? The answer is that between 5 and 10% of cancers are known to have genetic risk. There are associations, but we can only define between 5 and 10%. And here's just a number of genes, and there are different ones for different cancers. And it's just important to recognize that while we talk of cancer as a genetic disease, it's not always family associated. As Roy put up, 1 in 2 men, 1 in 3 women develop cancer. If it was genetic, it would be one out of every person would develop it. All right, next key principle to take home with you is that cancers evolve. And by showing this, I just want to show you that, and by defining terms, you have a normal cell, they become transformed. That's a buzzword in the laboratory. And that is a cell that's on its way to becoming a cancer, but it's not quite there yet. And in fact, you can see that the bar fight kind of action on the right side of my head, I had several pre-tumor lesions zapped off by a dermatologist last week. And these are nevi, or moles, and they looked uncharacteristic. And so it's better to zap them before they ever become a full cancer cell. Cancer cells then go through a benign phase. That's where they're just growing. But then they acquire the ability to invade. And invasion is the hallmark of the term malignant. And once cells begin to invade, they can then spread to other places. So just the ability to invade does not necessarily mean a person develops metastases, which is tumors in the second site, but it's the beginning, and that's what pathologists, those are the people who read those biopsies, are looking at. Okay, so it's important to know that cancers evolve. So, as the cancers evolve, has our thinking of cancers. Originally, cancers were described by where they occur in the body, and that's still how we define them. Breast cancer, brain cancer, skin cancer, that type of thing. But A few years after that, and we're talking about the 1700s or 1800s, people began to take out the cancer and look at those lesions under a microscope, and here are two lesions that represent phases of melanoma, skin cancer, and pathologists could look at the characteristics in those slices of a biopsy, and people were doing biopsies in the 1700s, believe it or not. Okay, that's when the microscope was first developed. After doing that, and that was prevailing for 150 years, people in the last few decades have begun to look at clinical subtype. These are markers on the cancer cell, characteristics of the cancer cell. And I'm using breast as an example here, where they have or don't have hormone receptors. Estrogen receptor, progesterone receptor, HER2, or those things. And you've probably heard those. A receptor is something on a cell that receives a signal. So these clinical subtypes have helped define how cancer is treated. If you have certain receptors or markers or whatever, the therapies are targeted to different ones of those. In the last 10 years, 12 years, that has evolved into much more detail in looking at the molecular biology. Don't worry about that detail. Glad to answer it, but it'll take longer than I have here. Where this is for breast cancer, but those markers and then other genes that are screwed up characterize breast cancer in 5 different categories. So it's not just breast cancer. There's luminal breast cancer A, luminal breast cancer B, HER2 breast cancer, inflammatory breast cancer, mucinous breast cancer, lobular, and you get the idea. It's a lot of different diseases. And that brings me to my audio visual. This is the part that's making Hope very nervous. Does anybody know what this is? Lasagna noodle. Farfalle bow tie. Okay. What do all of these have in common? You can eat them. They're all pasta. If I say we're going to have pasta, each of these noodles behaves differently in every dish. If I say you have cancer, how those cancers behave depends on which pasta they are. Okay? This came about at a dinner with Cheryl at Brio the other night. We were both inspired, and the manager looked at us like we were nuts. But that's okay. Okay, so molecular types have evolved. And only in the last 4 or 5 years, taking all those molecular things and combining them and putting them together, an individual mutation in each of those genes has helped define multi-genes and looking at each and every one of those. And I'm showing you here just the timeline. Where does it occur? The first cancers were diagnosed and treated in 2000 BC in Egypt. They used surgery, they used chemotherapy, and they did immune therapy 4,000 years ago. That's why we call it research, okay? And sometimes people need to go back and look at what was learned. So I've been leading into this. Every cancer behaves differently. And I know this is a bit of a gross picture, but you're a little further away from breakfast and still far enough away from lunch not to throw up. But this particular man has a tumor. They've removed part of the skull, but you can look at that tumor and you can see dark pieces or light pieces or some that are flat, some that are raised up. Each of those is a different behavior, and each of those determines the kinds of therapy. So one of the questions I was challenged to answer, and I'm not really going to answer it, but I'm going to do my best, is to try and answer the question, why is cancer so hard to cure? First of all, cancer cells don't do anything except be immortal that some normal cell does not do, right? So cancer cells invade. Our white blood cells are the immune cells in our body. They invade. all the cells in our body are able to grow. Cancer cells grow. So this leads to a challenge in regard to treating cancer, because when you treat, you're targeting something you hope is specific. That's why antibiotics work. They target bacteria, but don't have much of an effect on our cells, okay? They have an effect on the bacteria throughout our body, but they target bacteria. So far, we don't have, for the most part, something that targets only a cancer cell. That's evolving, and some of that CAR T therapy may lead to a new therapy. And the picture that I'm showing you there, the little diagram, the spider kind of thing on the left, is from a baby developing a mammary gland. By the way, men have mammary glands, just in case you were wondering, and men can get breast cancer. On the right are the evolution of cancers, different kinds of cancers. The markers are the same between normal mammary gland and the cancer cell. So it becomes a challenge. Here's the big word, trying to define jargon, heterogeneity. When you buy milk, they call it homogenized. They've tried to make it so it's not separating cream from the rest of the milk. That's homogeneity. Heterogeneity is when things separate, they become different. Cancers are heterogeneous, and that can occur at a lot of different levels, and I'll come back to that in a minute. I've mentioned genetic and how frequent that is. It's an evolving target. Roy was using that. Cancer hasn't given up. And I kind of like to think of cancer cells like sleeper cells that terrorists might put in to our body. They can become activated, and we still don't know how. And that occurs in the realm of metastasis, which is the reason that 90% of cancers, or 90% of cancer-related deaths are associated with metastasis or spread. So how do they metastasize? There are a number of different ways, and I like these pictures, so I'm just going to show them. They can spread, tumor cells can move around the body in the lymphatics, or they can move around in the blood, and the big fancy word coelomic is a body cavity. So bladder cancer can move across the bladder, it just floats across, or ovarian cancer spreads through the belly and adheres to the diaphragm and that type of thing. So you can have these tumors, they spread around by these routes, and they can grow in different tissues. My former students used to laugh because I drew this picture when I was a graduate student, and I used to put it in every presentation I gave, every one. And they'd say, "How dare you do that?" And I said, "It took me 3 days to draw this." And I have no artistic ability whatsoever. But you can look at this and see that metastasis is a lot of different steps. So to make a tumor, you heard me talk about those 10 hallmarks of cancer. There are 10 or more steps in the decathlon to make a cancer cell become a secondary tumor. But importantly, what happens is that cancer cells spread to another tissue, and then they grow to make a satellite tumor. And one of the common mistakes that I hear, I think you will hear, is that a metastasis to a tissue is different. So breast cancer that has moved to the bone is still breast cancer. It's not bone cancer. Or when it moves to the liver, it's not liver cancer, it's still breast cancer. And you can do this with all the other cancers. And unfortunately, the pitiful journalism that is done on television or in magazines perpetuates this. They talk about bone cancer from a breast cancer patient. And it's important that as advocates, you help educate people just as much as you can. This idea of heterogeneity, I want you to recognize it's at multiple levels. Every patient's tumor is unique. So Mr. Smith and Mr. Jones they can both have prostate cancer, but those two prostate cancers are different. Same thing for pancreatic cancer, whatever. If you have more than one tumor that happens to develop in your body, often women with breast cancer in the left breast develop another one in the right breast. Those are different, all right? You can have cells within the tumor. Those are different. Where the cell is, you can have the one cell that divides to make two, and if they separate, their position changes how they behave, because one may be closer to a blood vessel and oxygen and nutrients, and the other may be resistant to that. So this is a huge complication, and what it ultimately does is it leads to resistance to the chemotherapy or the immune therapy or the radiation therapy. So different cells behave differently. Despite all of these complications, there has been progress. And I'm not going to steal his thunder, or actually he stole my thunder, but I'll steal it back from you. These are statistics from the American Association for Cancer Research Progress Report. And I deal with metastasis, and I think one of the best ways for me to describe the progress that's been made is that when I was a graduate student, no woman diagnosed with breast cancer that had already metastasized lived 5 years. Usually it was less than 2. Now 40 to 50% live 5 years. Not good enough, but at least there's been progress. And that's because of folks like yourselves who are driving the agenda. So, what are the take-home messages? Cancer is many different diseases. Breast is not the same as brain, it's not the same as prostate, it's not the same as ovary, ... It's complex, duh. And it's evolving. The target today is not the target tomorrow. What we know today is not enough. Otherwise, we could put this baby to sleep, and I would personally like to be put out of this job. I was accused at my high school reunion a few years ago by one of my former classmates, "You don't really want to cure cancer because there's too much money in it." End quote. I will tell you, I would live at a much better lifestyle if I cured cancer, because people would be throwing money at me to tackle something else, okay? So just put that one away. Just shut them down if they ever say that. We're learning today through the research we're doing, and we'll know more tomorrow, but it still won't be quite enough. And I think really importantly for this group is that you can influence the direction of research by making sure that researchers and clinicians recognize those issues that are most important to you. Not only quantity of life, but quality of life. And you can also change the pace of research, because by interacting and focusing on the important things, the pace will change for the things that have the greatest impact.